Okay, so continuing on with our lectures on hormones, today we're going to look at somatotrophin or growth hormone. Shirt check, we've got Brighton Hove Touch Rugby casual shirt. So yeah, quite cool, nice size, nice fit, and let's get on with it. So if we talk about firstly what the hormone is, where it's expressed, so that's on chromosome 17. It's a peptide hormone, amino acid derived. Basically it has two effects that it can help with growth, so either direct by binding to receptors in adipose tissue and stimulating lipolysis, or indirectly by stimulating the liver to release these insulin-like growth factors IGF-1 and 2, and these are sometimes called somatomedins. Most of these are released during sleep, and they usually occur in pulses. So if you take a person's random blood test to check their growth hormone, you may see that they may be below normal. So what does the hormone do? Obviously it promotes growth, as the name suggests, also protein synthesis, carbon lipid metabolism, and more is released during exercise and hypoglycemia. Growth hormone increases hepatic glucose production, and that's done by gluconeogenesis and glycogenolysis, and this decreases tissue uptake of glucose, therefore increasing blood glucose concentration, and could lead to ketosis in diabetics. So some of the hormones that have an effect on the growth hormone, cortisol, so our stress hormone, as well as insulin, both decrease it. However, on the opposite side, we've got glucagon and thyroid, which increase it. Also, as we talked about, that more is released during hypoglycemia, during hyperglycemia, so when there's high blood glucose, less growth hormones released. And what else controls it? So if we think about that three-step way with the hypothalamus and the pituitary, so the hypothalamus releases growth hormone releasing hormone, and then the pituitary releases growth hormone, so we kind of miss out that last step of any gland. It's just straight from the anterior pituitary out to the system. We also have the somatostatin, which is a hypothalamic peptide hormone, which decreases growth hormone release. We also have ghrelin, so this is hormone that's produced in our digestive tract, and it increases our appetite, so makes us hungry, and that will also increase your growth hormone production. So therefore, how can we test for growth hormone when someone comes in? So we can give them this glucose load test, in which when they have an increase in glucose, we should see a decrease in growth hormone. Then we have these levels of IGF-1, plasma somatomedin C, so that's a different derivative of these somatomedins, such as the IGF-1. We can also have an exercise test, which we should see to increase growth hormone, as well as this insulin-induced hypoglycemia test and arginine as well. So what happens in the disorders? So you can either obviously have too little or too much of the hormone. So we've got deficiency in the form of dwarfism, and this splits off into two categories of disproportionate, which is genetics, such as achondroplasia, as well as proportionate, so we've got deficiency or metabolic consequence. So that could either be pituitary dwarfism due to this isolated growth hormone deficiency, or it could be panhypopituitarism, and that's due to the deficit of many adenohypophysis hormones, so not just growth hormone. On the other end, we've got growth hormone excess, which can result in giantism or acromegaly. So before epiphyseal plates are sealed, as when we're growing by estrogen, kids end up having giantism, and that can result in delayed puberty, vision difficulty, large hands and feet, and the most common cause of this is a benign tumor of the pituitary gland. On the other side, if growth hormone excess happens after the epiphyseal plate seals, we have this acromegaly in adults, and that can result in large hands and feet, facial features, and enlarged tongue, and again, a benign tumor is usually the cause. The deficiency in adults isn't well understood, but we see fatigue, loss of muscle strength, impaired psychological well-being, and adverse cardiovascular risk. Lastly, we talk about the growth hormone resistance, and this is called Laron syndrome. So what happens is that receptors, such as on liver cells, are defected and can't properly respond to growth hormone. So what happens is that we can have normal growth hormone circulation in the blood and normal release. However, when that growth hormone reaches the liver, because the receptors are faulty, we don't get this release of IGF-1 and 2, and that's you can measure that and see that those levels are low, so that would indicate that. And we've got some reference ranges here on the right that you can have a look at. It's also really good to read the Clinical Chemistry by Marshall and Human Metabolism by Frayne and Evans. So yeah, have a look. The links to those are in the description, so check them out and make sure to use my link Also, any trials that you would like from Amazon, all down in the description. And yeah, don't forget to leave a like, subscribe, share around. And yeah, hope you have a good day. Move on to the next hormone in the next lecture. Cheerio.